Hello, everyone, and welcome back. This is the second mini lecture for week 6, so week 6, part 2. And we are going to pick up where we left off with step 4. I do want to say really quickly that for the last slide for step 3 under creative approaches, there is a short video on sand tray that is in your Canvas course. So do take a moment and watch that if you haven't already. And moving into step 4, integrating the senses. So when we're talking about integrating the senses, we really want to focus on rhythmical interaction to establish internal sensory integration. We're going to talk about some different methods that are helpful for that, including mindfulness and somatic interventions. So what is mindfulness? Many of you may already know what mindfulness is or have an idea of what it is. You may already have a mindfulness practice. But in general, when we use the term mindfulness, we are talking about the capacity to maintain awareness and openness to your current experience without passing judgment and with having full acceptance of the way that things are. Part of this is not labeling anything as good or bad, including your thoughts and your feelings, and the ability to stay present and have self-acceptance. And all of these are really important to trauma work. I think finding acceptance around the way that things have turned out since the trauma, whether that's internally in your own body, in your own mind, and externally, it's really an important step because it's very hard to move forward without first accepting where you are in this exact moment. And so mindfulness activities really can be used from the very beginning to the end of treatment, but they are particularly helpful around reintegrating the senses into your personhood and your sense of self during this step of treatment. So you could use mindfulness in the beginning when you're teaching grounding and psychoeducation, but it also has a great place here in step 4. And I have to tell you all, I found this little brain meditating picture several weeks ago and have just been waiting for the right time to use it. And I think this is it. So I hope you appreciate that as much as I do. So using mindfulness interventions is something that almost any practitioner can do as long as you are familiar with the intervention, you've practiced it, you have a goal in mind, so an intentional use of it, and it's a good fit for your client. So you always do want to assess for appropriateness and readiness because there are times in trauma work that mindfulness feels very unsafe. Especially if the person is still very hyper aroused, if they cannot work through their trauma narrative without becoming flooded or reacting to it, then they're probably not ready for a sort of quiet time to be in their mind because their mind does not feel like a safe place. And so definitely assess appropriateness and readiness and talk to the client about what kinds of mindfulness interventions are going to work for them. For some people, guided meditations work really well, but non-guided meditations feel very threatening. For other people, meditation period doesn't feel good, and so they would rather do something like a progressive muscle relaxation. So there are lots and lots of options, and I think familiarizing yourself with the many options is a good starting point so that you can offer your clients almost a menu to choose from of mindfulness activities. Because when you are using mindfulness, you start reconnecting the person to their body and their brain as one integrated, holistic human being instead of feeling these disparate parts that have been sort of shattered by the trauma. So they're very powerful interventions, even though it can seem simple on the surface, but it needs to be a good fit for the client. As I put in one of my points here, mindfulness is almost a purposeful alternative to dissociation. So we know that dissociation often happens without the person meaning for it to. It's like a coping mechanism that the brain just takes over and says, we are not safe, so we are getting out of here. And your body stays in the moment, but your brain does not. And when you teach a client mindfulness, they are able to, instead of defaulting to dissociation over time, teach themselves mindfulness techniques to stay in the present moment without judgment and without labeling things as good or bad. And that can also help with healing the brain's inability to contextualize between dangerous and non-dangerous situations. So like I said before, there are lots of different types of mindfulness. If you are very, very interested in this, you may want to get some advanced training. Some of the advanced trainings that I would suggest are ACT, acceptance and commitment therapy, which has a lot of uses outside of trauma. I've done some trainings and actually given one training on this. And I think that it has a lot of techniques that are concrete, which can be helpful sometimes when people are recovering from trauma, to have those concrete activities to work through in counseling, or dialectical behavior therapy, which is more behavior-based, and has lots of uses outside of trauma as well, such as eating disorders and addiction. So those are some options if you are interested in furthering your education on specific mindfulness techniques. You could also think about starting a structured group for mindfulness for your clients or for other clients, or having a group that you can refer clients to. One of these is the mindfulness-based stress reduction group, and I did link in your Canvas account how you can go through a free training in MBSR, and I think this is a great resource. I've done it before. I find that it builds like skills that are useful across the lifespan, not just in trauma. So I think that that's a really good way to learn more about mindfulness in a structured format. And then of course in groups, which you haven't taken group yet, but you will soon, there's so much healing that can happen through the group process, and learning these skills and practicing them together can be very powerful. So let's talk about somatic therapies. You've been reading about these some in The Body Keeps the Score. So a lot of this is not going to be new to you, but somatic therapy is a term that really describes a broad category of interventions. But what it means is that somatic therapy emphasizes the connection between the mind and body. So you're really working to reduce and hopefully extinguish the dissociation that happens and the disconnect that happens between the brain and the body after a trauma. And a lot of somatic therapy is based on Eastern medicine and spiritual practices. I would also say indigenous spiritual practices. And it is really important when you use these therapies to understand where they come from, and I think give credit to the ancestors that came up with these very, innate types of treatments that we're now using in sort of a medical or clinical setting. So I think that that's just something that we need to know when we are using this type of treatment. And, just like we use land acknowledgements, make sure that we understand where we are getting this wisdom from. So some of the main ideas are all aspects of the human experience are connected, and when we have disequilibrium in one part, that affects all parts of our body. We've certainly seen that come through in the research as well. Another main idea is that body movement in the treatment of trauma can assist with integration of the trauma that is stored in the body. And even our more advanced trauma techniques have, I think, are built on that idea. Things like EMDR and brain spotting that we'll talk about shortly are based on this idea that trauma does get stuck in our bodies and in our brains, and we have to find a way to integrate it to move forward. And so there is a growing emphasis on this type of therapy in the research, but it is still limited. So somatic experiencing is based on Peter Levine's work, and I would really recommend reading his books. They're not super long. I have read at least 2 of them. They do typically have specific activities in them that you can use for trauma treatment. And it's based on the idea and from his observations of animals who survive a trauma. So if you think of like a gazelle that's being chased by a lion that gets away, what will often happen is that after the sort of moment, the moment when the animal realizes that they've survived, they will tend to shake pretty severely and until I guess the body just releases all of that adrenaline and potential, hormone flooding from the trauma. And so he's built all the somatic experiencing work off of these reactions and observations of animals after a trauma or surviving a fight, flight, or freeze situation. So the goal with somatic experiencing is to resolve that energy that's associated with survival. And so after you have survived, the idea is that you do have this energy within you that is, hormones and chemicals from the survival, and that we need a way to get it out in a safe place. And so it really is dealing with like lower brain activity. Some of his work references the reptilian brain. That terminology has kind of gone out of fashion or out the door. This idea of a reptilian brain is the language around it does not have a lot of a strong basis in the literature. However, that's sometimes still what the lower brain gets referred to. So if you see that, that's what it's talking about. But like if I were writing something today, I wouldn't use the term reptilian brain. So anyway, that's besides the point, just a little note on language. But the idea is that after the trauma occurs, we need a place to be safe and physically get it out of our system so that the amygdala can calm down. If you remember, the amygdala is the fire alarm in our brain. So we need to calm down the fire alarm, calm down our system, and allow us to move forward in putting together our trauma narrative and begin healing. So somatic experiencing can be really helpful for this. I would suggest you pause this video now and go into Canvas and watch the Peter Levine video that I have there for you. All right, so that is all for step 4. So we talked about mindfulness and we talked about somatic techniques, and there's lots of further learning you could do on that if those interest you. The next couple of slides, we are going to talk about advanced trauma techniques. And if you plan to have a career in trauma work, or even be a generalist in your rural town where you get a lot of different referrals for different age groups and different problems, I would suggest looking into further advanced training in at least one trauma method. It can be costly, so I'm certainly not going to underplay that, but I do think that to make sure you can integrate both brain and body work, the advanced trauma techniques have so much support now that you'd almost be doing a disservice to your clients if you weren't trained in this. And I will say on the front end, I'm not trained in any of these. Almost all of my training was in trauma work with kids. And so, like I mentioned before, I have trainings in trauma-focused CBT. I have trainings in filial therapy and lots of other, child-centered play therapy and trauma for that. However, if I were still in practice today, if that were my main job and not being a counselor educator, I would most certainly have a training in EMDR most likely, and possibly neurofeedback. So that's just my sort of 2 cents on advanced trainings. I do think that they are worth the investment once you graduate. So the first thing we're going to talk about is EMDR, eye movement desensitization and reprocessing. This was created around 1990, and it is well researched and supported as a trauma treatment, and it's a very structured approach. So clinicians use bilateral stimulation. Sometimes that will be a light bar where the light goes back and forth and you follow it with your eyes. Sometimes it will be just hand signals. Sometimes they also use items that you place in your hands that will vibrate one side and then vibrate the other side to stimulate your brain from one side to the other. And so the theory that this is based on is that bilateral stimulation promotes cognitive processing and recontextualization, right? We keep coming back to that all important point that for trauma work to be effective, we need to be able to help the client put context back into their processing. And so recontextualization of the traumatic event and the related material. And so the client will work through their traumatic memories and associations while engaging in the EMDR practices, the bilateral stimulation, in a safe and calm environment. There are different levels of training you can get for EMDR. It does take time, it does take studying and practice, it requires supervision, but in general, I think this is a great advanced treatment option, and one that I would recommend anyone who's going to, work in trauma long-term seek out. Next, we have brain spotting. Oh, and let me also say there are videos in Canvas for each of these. And so I hope that you will either stop the video and watch them after I finish giving you an overview, or once you finish my video, go back into Canvas and watch each of the short videos on these different techniques. Most of those videos are well under 10 minutes. There might be one that's around 10, but most of them are like 2 to 5 minutes. And so it shouldn't take you too much time to learn a little bit more about these techniques. I think that will also give you more information that you can think about as you go into practicum and internship and consider advanced trainings after graduation. So that's my little spiel about the videos in Canvas. So brain spotting was created by David Grant in 2003, and he was doing work on athletes when he sort of made this discovery. It's less research, but there is strong anecdotal support. And I will say there's more research coming out. Anytime you have an institute, there's going to be research that is produced on a technique. But very similar to EMDR, it is based on a theory that, there are parts of our brain that contain the trauma, and we need to unlock those so that we can integrate that into ourselves and move past that fight, flight, or freeze stage. And so with brain spotting, the theory is that dissociation occurs through specific eye positions. If you can think about, like, if you've ever caught yourself staring off into space, like maybe you can't even remember what you were thinking about, you were thinking about something. Or maybe your body was or your brain was processing something. So those specific eye positions, just sort of where your eyes go and rest, are called brain spots. And the belief is that your body has an innate ability to locate these brain spots and then work through the maladaptive aspects of what's happening in your brain from the trauma. So this again is an advanced training. I wouldn't say it is as intense as EMDR. In fact, I have a friend who did the training through like pre-recorded sessions. It was still, costly, not as costly as EMDR training, but also not inexpensive. But it can be something that you do within like electronic training, and it doesn't require quite as much of the supervision piece as EMDR. But through this type of therapy, a brain spot is identified by a client or therapist, and typically the therapist will have some sort of pointer to help the client identify a spot. And then once you're looking at that spot affiliated with the brain spot, you would be asked to think about your emotions and experiences and cognitions around the traumatic event. And the theory is that while your eyes are in this fixed location, your brain has more time and space to process the material. So that sounds complicated, right? And maybe a little like, okay, that's different. But like I said, it has some good evidence to support it, and we don't fully understand how the brain stores our trauma and also how it releases it. So this is something that you might want to look into or be interested in. Definitely watch the video. They're probably going to do a better job explaining it than I have. I actually learned about brain spotting when I was on a response team for the Sandy Hook shooting. I went there and worked with some other therapists who were doing this more specific trauma work. I did more of the group work, so I ran some of the trauma groups for the educators and administrators and other people that were affected by the shooting, and then we had more specialists that were coming in and doing this type of work. So really interesting, still pretty new out of the therapies that we're going to talk about. All right, neurofeedback you already learned about in your book, so I'm not going to say too much about it, but it is the neurological extension of biofeedback. It's been around for a long time, probably longer than the previous two techniques that we talked about. It does teach clients to self-regulate their arousal through operant conditioning. It's essentially trying to get your brain to work at, the optimal level. And when it does that, it reinforces it. My best friend from high school is actually a neurofeedback therapist and has gone through the training. And so we've talked about it at length. And while I still, don't have the expertise that she does or that other practitioners do, I have a lot of positive thoughts and feelings towards this treatment. I think it can be really helpful. This is probably, I would say, the most time intensive type of training that you would need. There is a separate credentialing board for neurofeedback. I'm almost sure there's a test that you would take, but don't quote me on that. But you do, so the therapist does attach the EEG while you're in session and measures your brain waves to target whatever aspect that you are wanting to treat. And neurofeedback doesn't just treat trauma. There are lots of different conditions that people seek treatment for in neurofeedback, including ADHD, sleep disorders, and other things like that. So check out the video on that as well. And then next we have EFT, or the emotional freedom technique, which may also be called tapping. And this is actually a pretty simple, compared to the other techniques that we've talked about, way for you to incorporate some advanced body work in your systems. EFT, it doesn't have a ton of research behind it, but there are some promising studies out there. And it involves teaching clients a routine of tapping on acupressure points, combined with statements that are affirmations and restructuring some of the thoughts that are contributing to their distress. And so the goal is to help your mind and body come together to process those memories and incorporate them and integrate your trauma back into your full system. And so EFT, I think, is interesting. I've used it some off and on for my own sort of like, sometimes when I can't sleep, I'll pull up an EFT video, or if I'm feeling anxious. For me personally, I probably don't do it enough to have lasting benefits, but I do find that it calms me and it helps me focus on my breath and be in the present moment. And so I think that it's a good technique to know for lots of different reasons. And if you invest time in learning more about it, it could be something that becomes sort of a go-to for use in trauma sessions. So definitely check out the video that I linked for this. And I would say, I want to say this is the longer video. Try to follow along and come up with your own like statements when the presenter is walking through it. All right. Next, we have prolonged exposure therapy. I mentioned this briefly when I was talking about narrative exposure therapy in a previous week. And this is a long-term approach used by the VA to treat PTSD. Prolonged exposure therapy is effective. However, it also has about a 40% dropout rate because it can be very difficult for a person to get through those initial exposure sessions. And so even though, it's titrated through like psychoeducation, imaginal exposure, and then in vivo exposure, sometimes that can still be too much for clients. So I would say use this with a lot of caution. Make sure you get extra training if you're going to use this. Maybe try other techniques first before moving to exposure therapy, because I do think there's a higher risk of re-traumatizing clients with prolonged exposure therapy than many of the other therapies that we've talked about. So, is it effective? Yes, we have lots of research showing it's effective. Could it also be harmful? Yes, we also have lots of research indicating that it could be harmful. So, I don't want to completely dismiss this treatment because it has proved to be effective in the long term. However, it does not address a lot of the underlying issues with PTSD. It's just focused on behavior. And so you could be missing some things, and you could also be re-traumatizing your client. So be careful with this. If you choose to use it or look into it, make sure you do a good bit of training before you do that, and make sure that your client is appropriate for it. And just some other considerations, if you are not trained in an advanced trauma treatment, you can refer out. So having a good referral list is always really helpful, I think, for any type of work that you do. So know who you can refer to. If somebody needs a primary doctor, have a couple of referrals for that. If somebody needs, psychiatric care, make sure you have some referrals for that. And this is another type of referral that you could have. So if your client wants to seek EMDR treatment or neurofeedback while they're also in counseling, that is perfectly fine, as long as there is an understanding that, you're going to work on A in your therapy sessions with them, and they're going to work on B in their neurofeedback or EMDR sessions. I would also really strongly suggest that you have a release sign so that you and the other practitioner can talk to each other and track progress, and also track any like symptom reemergence or other issues that could come up. But it is perfectly fine to offer both of those through different providers, as long as you're working on different things. As I mentioned earlier, one of my good friends is a neurofeedback therapist. She doesn't do a ton of talk therapy because most of the work that the people are doing when they're in neurofeedback is brain-based conditioning. And so many of them will have another therapist that they do talk therapy with. So that's a pretty normal process. Other therapies that you're going to want to consider for your clients could be anger management or skills training. I think that trauma brings up a lot of anger in us, and especially when it has impacted our life and our functioning and sort of the way we used to be, that now we have this new self that we don't want to accept, And while we can work with the client on through mindfulness and other grounding techniques and all that to help hopefully get them closer to acceptance, having other skills and managing the anger around that could be helpful. Group therapy, as I mentioned earlier, can be really helpful. You could offer this as an adjunct to your individual sessions, or you could have another counselor that you refer out to for group therapy. Typically, and you'll learn this when you have your group therapy course, but we move into group after the bulk of the individual work has been done. Unless there's some very specific reason why you think a person would benefit from group and individual concurrently. You may refer someone to group when they're like seeing you once a month for individual or something like that. Group counseling has really good research behind its effectiveness, almost as effective as individual therapy. And of course, it's very normalizing for the client to see other people who are struggling with similar issues. Some other things to consider are exercise and other stress relieving techniques, massages, things like that. Things to help get our endorphins, moving and helping us feel better. Vocational therapy, because we know that trauma can impact one's ability to go back to their job or continue in their job, specifically if it was a job-related incident that led to the trauma. So some career counseling might be helpful here. And then, of course, a psychiatric evaluation is typically helpful as well, especially if the person has symptoms that are incredibly somatic based, or that you cannot break through if you've been in treatment for over a year and you're doing all the things and they're working really hard. I think that a psychiatric evaluation is a good next step because they may just need that extra level of care. So those are some thoughts on other considerations for trauma therapy. That is all for this mini lecture. I hope that that was helpful for you, and please know that you can leave me some questions either in our classroom discussion or in over email. So have a good day.